Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up or press the like and subscribe button. Now, without further ado, let's get into today's topic, which is the acute hot joint and septic arthritis. So there's quite a lot to cover in today's presentation. We'll first of all just go over the definition of an acute monoarthritis or an acute hot joint. So, as the name suggests, this is a single red, hot swollen joint of less than 6 weeks duration. Septic arthritis specifically is the most serious cause of acute monoarthritis due to infection within the joint. It's difficult to know the exact epidemiology, particularly worldwide, but we do know that 7 to 15% of people who are diagnosed with septic arthritis and admitted to hospital do die. In terms of an acute hot joint more widely, as we've alluded to, an acute hot joint is septic until proven otherwise, and this is really important for investigations and management. However, there are lots of other causes which we have gone through in previous presentations, so do take a look at those if you'd like to know more. So some examples are gonococcal arthritis, and this is the commonest cause of a monoarthritis actually in young sexually active adults. Other very common causes are gout and pseudo-gout, particularly given the population that are admitted to hospital with other diagnoses and conditions. An acute hot joint may herald the start of an inflammatory wider condition such as psoriatic arthritis or a seronegative arthritis or indeed rheumatoid arthritis. And then it's important to remember the other non-rheumatological causes such as trauma, hemarthrosis, and also be wary of mimics such as cellulitis. In terms of septic arthritis itself, the commonest organism causing this is Staphylococcus aureus. In rare cases, multiple joints can be involved, and it's important to bear in mind risk factors, particularly when assessing a patient with a hot joint. So these include advanced age, pre-existing joint disease such as an inflammatory arthritis, diabetes mellitus, immunosuppression, and intravenous drug use. In terms of assessing someone with septic arthritis, so the most obvious thing to look for is an acute swollen hot joint, which may be affecting one joint or may indeed be polyarticular. If someone does have septic arthritis, they are likely to be quite unwell, maybe even spiking fevers, and the joint will have very limited range of movement, and if it is affecting the knee, which is the commonest joint to be affected by septic arthritis, then the person will have difficulty ambulating. In terms of investigations, these are quite wide-ranging, so as ever, it's important to do bedside observations and a urine dip to check for signs of infection, and obviously at this point you'd be wanting to check one's temperature. In terms of blood tests, it's important to do a full blood count, renal and liver function tests, as well as inflammatory markers. It's also important to do a uric acid test in case the cause of a hot joint is gout. And one may consider to do a rheumatoid factor and CCP antibodies if an autoimmune inflammatory arthritis is suspected. Blood cultures should also be performed at this point. The most important investigation to do prior to antibiotics being commenced is joint aspiration with urgent microscopy, crystal analysis, gram stain, white cells, and culture with sensitivities. And this is the gold standard test for testing for septic arthritis. A joint X-ray should also be performed, preferably before aspiration. There are some contraindications to joint aspiration by the medical team, and these include overlying cellulitis, because you do not want to introduce an infection into a joint that may otherwise not be infected. If there is any suspicion of osteomyelitis, then that patient should ideally be referred to orthopedics. And also, in the presence of a prosthetic joint, orthopedics should be involved, and the patient should be referred to them. It's important to note that a high INR or anticoagulation use is not a contraindication to joint aspiration in an emergency. The management of septic arthritis is as you would treat any septic patient, so fluid resuscitation and then administering antibiotics as soon as joint aspiration is done. Usually this will be IV penicillin such as flucloxacillin. Ultimately, the antibiotic therapy will be guided by culture and sensitivity results if found to be positive. Analgesia is important, and in a lot of cases, the joint will require washout by the orthopaedic surgeons. It's important to rest and immobilise the joint as well during treatment. So let's move on to some questions. Firstly, a 30-year-old man with a history of intravenous drug use presents to the medical take with a hot, swollen knee. On general inspection, he has a swollen, tender left knee with limited range of movement, both actively and passively. The IMT1 doctor performs a joint aspiration, the result of which shows a white cell count of 120,000. Which of the following statements is not correct? So I'll just give you a moment to look at that question before we go on to the answers. So, we're looking for the answer which is not correct. The options are 2 grams IV flucloxacillin QDS is indicated with a stat dose after aspirating. Pseudomonas needs to be considered. Measurement of lactate is necessary. An INR of 4 is a contraindication to joint aspiration. An X-ray of the left knee should be performed. So in this case, the correct answer is an INR of 4 is a contraindication to joint aspiration. This is not true. A high INR is not a contraindication, particularly in an emergency, and the joints should be aspirated. In this particular case, the patient is an intravenous drug user, so there's quite a high chance that he may have contracted an infection, and therefore all of the other answers are correct. Here's the second question. So a 50-year-old lady with known rheumatoid arthritis on methotrexate comes in with spiking fevers and a hot, swollen erythematous right knee of 2 days duration. She has recently been in hospital with pneumonia. The joint is aspirated and shows gram-positive cocci in chains. Which organism is most likely to be the cause of her septic arthritis? So here we are told she's got septic arthritis and we are given the gram stain. The options are Staph aureus, E. coli, strep pneumonia, Pseudomonas, Mycobacterium tuberculosis. And the correct answer here is strep pneumonia, not just because of the gram stain, which tells us that they are gram-positive cocci in chains, which would be consistent with a diagnosis of streptococcus, but also we know that she's recently been in hospital with pneumonia, and therefore this is a plausible explanation. So thank you for listening to this episode of Bite-Sized MRCP. If you like the sound of what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear from us in future, and we will see you for our next episode.